Buenas noches, en nombre de nuestra presidente, la doctora Yolanda Zamorano Orozco y todo el Consejo Directivo, les damos la bienvenida a esta cuarta sesión mensual titulada Perfil del endoscopista del tercer espacio, curva de aprendizaje para llegar a ser experto. Contamos con la presencia del doctor Ariosto Hernández, que es nuestro profesor nacional invitado, quien es médico endoscopista egresado del Hospital Central Militar con una alta especialidad en ultrasonido endoscópico en el Instituto Nacional de Cancerología. Posteriormente hizo un fellow en endoscopía avanzada con orientación en tercer espacio en la Clínica Mayo y también fue profesor asociado de investigación de la Universidad de Estrasburgo. Adelante, Ariosto.
Muchas gracias, doctor Johnny Serna, por la amable introducción. El doctor Mohamed Othman es un gran amigo de la Asociación Mexicana de Endoscopia Gastrointestinal. Trataré de ser lo más breve para resumir su amplio currículum. El profesor Mohamed Othman ocupa la cátedra William T. Butler para profesores distinguidos y es profesor de medicina, medicina interna y gastroenterología en la Facultad de Medicina de Baylor. También es jefe del servicio de gastroenterología del Centro Médico Baylor St. Luke's y es miembro del Centro Oncológico Integral Dan L. Duncan de la Facultad de Medicina de Baylor. Los intereses del Dr. Othman incluyen la disección submucosa endoscópica, la resección mucosa, vigilancia y ablación del esófago de Barrett, pancreatitis crónica y aguda, quistes pancreáticos, detección de cáncer de páncreas para pacientes de alto riesgo, ecografía endoscópica, CEPRE y colangioscopía con láser, detección de cáncer colorectal y colonoscopía, miotomía endoscópica peroral, miotomía endoscópica peroral gástrica y resección endoscópica de espesor completo. El doctor Othman se graduó en la Facultad de Medicina de Mansura, Egipto, completó su residencia en Medicina Interna en la Facultad de Medicina de Nuevo México, Albuquerque, donde también fue becario de gastroenterología y hepatología. También realizó una beca de investigación en endoscopía avanzada en la Clínica Mayo de Jacksonville, Florida. El doctor Othman cuenta con certificaciones de la Junta Americana de Medicina Interna y la Junta Americana de Gastroenterología. Es miembro del Colegio Americano de Gastroenterología, la Asociación Americana de Gastroenterología, la Asociación Americana de Endoscopia Gastrointestinal y el Colegio Americano de Médicos. Entre sus numerosos premios, el doctor Othman recibió el Premio de la Diversidad en 2014 de la Sociedad Americana de Endoscopia Gastrointestinal. Muchas gracias, doctor Othman, por su presencia y vamos a comenzar con su presentación.
Thank you so much for such nice introduction. And for me, AMEG is my favorite association after our ASGE. And I get honored every time I get invited by AMEG and to see my AMEG friends and all the beautiful work you are doing for education and training in Mexico. Today, I will talk about a topic that's very close to my heart. And I feel passionate about training in ESD and who should be trained and who should not be trained. And we'll talk a little bit about that. So since the title includes the third space, I want to just give a quick introduction that the first space for endoscopy is the esophageal lumen, the stomach, and the colonic lumen. We call this the first space. And then when ERCP came, the bile duct lumen and pancreatic duct lumen consider them the second space. And the third space is the submucosa. Submucosa is that layer which is between the mucosa and the muscularis propria. And this layer acts as a potential space because it is expandable. You can inject in that layer and the layer expand, and that allows you to dissect into that layer. You can even put the entire scope into that layer. And that's how we came up with the term third space endoscopy. In the submucosa, there are inhabitants. There could be blood vessels, lymph nodes. Sometimes you can find a muscle tumor like leiomyoma. When you go in that area, you have to respect it. We can see here, we are dissecting and then a bleeding happen. And if you can quickly control it, everything will be fine. But sometimes if you don't realize that, you can have a major bleeding, which delay the procedure significantly. So you have to respect that space and its inhabitants. So dealing with submucosa is not a new concept. All of us, whether we do third space endoscopy or not, we are dealing with a submucosa. Because anytime we inject a lesion to raise it, this is part of dealing with the submucosa because we're injecting it. So I think there's a lot of terms that people get confused with. There's a term submucosal endoscopy, third space endoscopy, and ESD, endoscopic submucosal dissection. So I will try in this slide to summarize all these terms to make it easier for anyone who is not involved in that field. And basically, third space endoscopy is anything when you tunnel through the submucosa. So if we are doing a POEM per oral endoscopic myotomy in the esophagus, or doing it in the stomach, or doing it for Zinker, or for diverticulum, or tunneling to remove tumor, which we call the STAIR, or submucosal tunneling endoscopic resection, all of these procedures are third space endoscopy. Endoscopic submucosal dissection is totally different procedure. You dissect in submucosa, but you have to know the borders. You're not going in a tunnel. So third space endoscopy plus ESD, both of them is called submucosal endoscopy, but most of us think of third space endoscopy as a peroral endoscopic myotomies procedure versus ESD by itself. So after this terminology now, we can talk a little bit about third space and ESD, and I just will start by this consideration. It's from the European Society of Gastrointestinal Endoscopy, and they recommend against unsupervised ESD, especially chronic ESD in the beginning. So I trained a lot of people in ESD either in a formal training or in weekends course or proctorships. And one of the biggest mistake I noticed is these confident endoscopists that they're so good in what they're doing, they are so good in ERCPs and EOS, and they think that ESD is just another procedure that they can start and do it with no training. And very soon they can get themselves in trouble. So I remember one person who was so excellent that I trained in one weekend course for colon ESD, and next week he went to do right side colonic lesion. Spent 6 hours. After that, he had a colonic perforation, and the patient ended up going for surgery in the same night. And then I start teaching people not to do that. And a few years later, the same thing happened again with another endoscopist. So I'm seeing a pattern. So that's why I'm putting this before we start talking about it. In your initial experience, do not just go for right side chronic ESD without feeling comfortable. So the European Society of Gastrointestinal Endoscopy recommend that you have a curriculum and you start careful and start with a smaller lesion, maybe in areas that the risk of perforation is not that much, such as antrum or rectum. It is very hard to find an antral lesion because we don't see this lesion often as we see them in Japan, but we see a lot of rectal lesion. And yes, rectal lesion bleeds, but they don't have the risk of perforation. So a rectal case of 3 centimeter or a neuroendocrine tumor in the rectum might be your first case. And if you do a few cases like that, it will help you to get your confidence. So also the European Society looked at independent factors for procedure success in the hand of expert endoscopists who just started doing ESD without training in a fellowship. So basically, if you're like me and you who did not have ESD training and fellowship, and then you decided to learn in workshops, what is the factor that make you successful? People who start with rectal lesions, people who do cases without any submucosal fibrosis, people who do lesion less than 35 millimeters. All of these factors are associated with success of the procedure. And once you do 100 cases of ESD or more, you can start doing harder cases. And so I remember in my initial journey, 2014 and 2015, I would get referrals for ESD, which I would say, I'm sorry, I cannot do it. And this referral now, I easily do it, but at the beginning, I learned not to do it. Building your confidence is very important. So this is another proposal of learning curve for people who are, like the title of the lecture, the profile of third space endoscopists. Who is this person who should be doing third space? So there has to be a basic precondition. That person has to be interested in tissue resection to begin with. either have a practice of EMR experience, like he does a lot of EMR, or he's in a referral center, a big hospital that he gets all the referral. And sometimes people say senior endoscopist. I start to disagree with this. I actually have been training a lot of young people, and they're so good. If you train them well and they're careful, they don't have to be senior endoscopists, but they also cannot be somebody in his first year of training. Like you have to be doing endoscopy for 4 or 5 years till you develop this fine motor hand movement and you become good at it before you do an ESD. So now you have this requirement, you love doing resection, you're doing EMRs and feel EMR is not enough, and you want to learn ESD, allow yourself 1.5 to 2 years. In this 2 years, you have to start planning very well. So phase 1 of planning is a structural decision. What I mean by that, if your unit does not have carbon dioxide insufflation, you have to do carbon dioxide insufflation. If your unit does not have dedicated place for recovery, like our work in ESC, and you don't have a dedicated place to admit patient post-procedure, you have to think about, is this the right place to do ESD? And also, you have to think about your nurses. Can you do one case for 4 hours? Can they allow you to do that? Can you have a team that work with you all this time? So all of the structural decision is important. Then you have to do theoretical decision, which means you have to learn what ESD is, what are the indications, how you can look at the surface pattern of a lesion, how can you evaluate lesions with different, like chromoendoscopy or narrowband imaging. All of this are theoretical learning. So now you know your lesion, now you prepared your staff, you can go what we call preparatory training. And preparatory training is live workshop, ex vivo animal models, in vivo training in animal models, and also proctorships. All of these are preparatory trainings. And we're going to talk about them in details later on now. And then after that, you start doing your first stage, clinical ESD. Think of yourself in your first 40 to 50 cases, you are an ESD to be, you are to be an endoscopist who will be doing ESD. You're not there yet. Yes, you did all this training. Yes, you have this knowledge, but your first 40 to 50 cases, you want to do easy cases to be successful. And once you do that, once you get to 80 cases, now you become a skilled endoscopist. And now you have to start to look at your quality measures. You have to look at your M-block resection rate. You have to look at your R0 resection rate when you remove the lesion. If the margins are negative, you have to start looking at your adverse events. My suggestion is you have to have 90% end-block resection rate to be a good ESD endoscopist. And in my unit, we track for every one of us who's doing it. So this is an article I published in 2011 talking about ESD in the West. At that time, we're thinking we can start with gastric lesion and maybe do hybrid techniques. But right now, 14 years later, ESD in the United States is gaining popularity. We have more than 20 ESD referral centers, and I call any centers that do more than 50 cases a year a referral center. At Baylor St. Luke's, we do between ESD and third space 500 procedures a year. So this is one of the highest centers in the United States, almost as Japan, and it was a journey to build that from 2014 till now to get to that volume. Right now, I have many industry-sponsored robust training in ESD. I know also you are having the same in Mexico now. There are many ESD training courses. I heard about the course in Puebla, Mexico, with Latin Surgery Association in June, and I will be there. I think AMEG is part of that course too. And if you can see here in the United States, ESD is a planned area of expansion in every university. Every program in the United States is looking for someone who can do ESD. So the tide changed completely, and I think the same will happen in Mexico too. But we still have a lot of problems in the United States. Part of it is that some people don't even believe in this technique. Some people would say, I will do EMR. Or some people will say, why I will work 2 to 3 hours to remove a lesion? I will just go for laparoscopy or do this quickly with surgery. And also don't have enough data to show the superiority of ESD techniques over other measures, particularly data from the West. This was the first study for ESD prospective trial coming from the United States. and it was 600 cases. And this was the first time we showed that ESD can be performed in the United States in a safe manner in 10 centers with 91% in block resection rate, with bleeding rate of 2.3%, and very low perforation rate, 2.9%. So most of the people like me who started ESD, they had to go outside the United States to learn. You still can do that in Mexico. If you have the time to go to Korea or to go to Tokyo or to go to China, that's great. This is an images of me in versus various courses. And I will say our Asian masters endoscopists, in particularly Japan, Korea, and China, they really are the one who trained most of the endoscopists right now in America, North America, or South America, or in Mexico. So we know that, we owe it to them. If you can travel there, that's fine, but a lot of people cannot go there. So for these people who travel there and come and work on their own, in spite of them watching cases there, they still have a learning curve. In 2020, Dr. Stavros from New York, he put his cases, how long it took him to be efficient in ESD, to do 9 centimeters squared per 2 hours. And it took him 250 cases. And at that time, a lot of people said, that is too much. Why you need 250 cases to be good in ESD? So I did the same with my cases, and I looked at around 600 cases of ESD, and I found that I plateaued at 268. It doesn't mean that before that I was not doing a good job. You will do a good job, but if you want to consistently manage any lesion that comes to you, no matter where it is, closer to IC valve, closer to appendix, in a tough location, in retroflexion, then the number needed, at least in my training, was 268. Okay, I don't want you to be worried, because me and Stavros were trained long time ago, and I feel right now, I'll show you data, that you can actually shorten this learning curve, and actually it is possible to have it faster. So we talked about training, and we want to train in easy lesions such as antral lesion. We know that we don't have enough of these gastric lesion in the United States. Maybe in Mexico you have some of this early cancer, but the problem would be we don't have a screening program for that. In Japan, they do screening AGDs, and that's why they're able to find these early cancers. In the United States and in Mexico, we don't have a screening AGDs program, so by the time we discover gastric cancer, it is late. Also in the United States, insurance yet it does not recognize ESD as a procedure. This is a study I published in 2022 showing the variation in payment for this procedure. I want to highlight here for gastric ESD that I had one case that Medicaid reimbursed us $44 for 2.5 ESD, and some other private insurance give you $4,200. The payment is all over the place because there's no dedicated code for ESD. I assume you'll have the same in Mexico, and I assume having or determining the value of ESD is not that easy. In other countries that they have a cash payment, such in Middle East, I think they just agree on a price, like maybe 4-time EMR, and that will be our price. But in a system like in the United States, when you have an insurance, it is so hard to determine the price of the procedure. And this is one of the reasons that ESD did not take off as much in the United States, is because we don't have this dedicated codes yet. Spoilers, in 2027 in the United States, we might have a code. So we're almost there, and we're going to have a code very soon. So the alternative in the United States is esophageal adenocarcinoma. In Mexico, still, I think you have esophageal adenocarcinoma, but you might have more squamous cell carcinoma of the esophagus, and also colon polyps. And colon polyps, we often find it, and I'm sure that rectal lesion would be the best lesion to start with. In Mexico, the same as it is in the United States. So let's just take a step on the back. Why we are learning ESD, why we want to know that technique, is because we want to help our patient. So if you want to have a successful ESD program, you really have to address the need of the population of interest. If you live in Japan, it might be early gastric cancer. If you live in the West, it might be colon polyps and colorectal cancer. I know, for example, in Argentina, they have large population, like the colon polyps are high, and this happened from consuming red meat, the same in the United States. So in this population in Argentina and Mexico and the United States, we need an ESD program to address complex polyps rather than sending this patient for right hemocolectomy. You also want to provide a value that's superior to other modalities. For example, EMR is associated with 20 to 30% recurrence rate. I was just in DDW, and there was a study from Scotland, looked at all EMR cases done in Scotland, and they found that there is a recurrence rate of 30%. And they started to make some measures to improve EMR, and after that it dropped to 16%. When you do ESD, your recurrence rate is 0%. So that is a value that you provide by ESD that you cannot provide with EMR. And also ESD can complement already existing program. So if you have a program for Barrett ablation, you can convert it and do that. So how can you start the program? You have to start teaching the physician. So here in Houston, my physician know the difference of EMR versus ESD, and that's because I keep visiting them, showing them images, explaining to them. So you have to go to your physician, tell them this is a technique, this how can help your patient. A lot of patients would find me through the internet and come for second opinion. And when I do resection, I found who is the doctor who did your original colonoscopy and referred them for the surgeon. I contact him and nicely told him, hey, I got one of your patients. He was supposed to go for surgery, but he came to me. This is how the lesion looked at the beginning. How the area looks after. These are the results. He did very well. And all doctors would like to help their patient. And a lot of them, once they know that you are able to do that, they will send you other patients. So think about it. It's not only about learning the technique, but once you become good at it, you have to teach others so that they send you these cases. In your hospital, they may not be happy initially that why you're doing this, why you're wasting your time and our time. And in this situation, you have to explain to them that there is a downstream revenue because some of this patient may require surgery, and this patient may not come to our hospital if we don't offer this service. You also can explain to them that this cost saving for the entire healthcare system. So if you work in a department of health, your patient will be served by having colonoscopy and remove the lesion rather than a major surgery, which will cost the system a lot. You can also convince your hospital, if you are in private practice, that this will improve the hospital ranking and staying competitive. The message is you don't do this alone. There's other people you have to convince. And one of the main people you have to convince is your anesthesia. They have to understand that this is not a standard endoscopy. You have to encourage general anesthesia. You have to make sure that your patients are intubated and you can measure their peak inspiratory pressure so that if air goes to the peritoneum, you can see the increase in peak inspiratory pressure and put a needle to decompress the abdomen and get the air out, as I'm going to show in a video later. For your technician and nurses, you don't want to teach everyone ESD. At the beginning, limit the training in ESD to 2 to 3 teams. And also, you have to teach them the energy settings because sometimes you might be marking the lesion in soft bag, and then you have to switch to another mode. And instead, if you're doing all these things, invest in teaching your team about the energy setting and why you are using what we are using. So investing in your team and teaching them this new procedure is important and is often neglected by some physicians who just go and work with whoever in the room. No, insist in having a team for ESD, and they will be so good. Right now, my technician who has been working with me for 10 years are the one helping me to train people. So I keep talking right now about doing colonic ESD, but the reality is in the United States, it's so hard to do colon ESD because the wall of the colon is thin and there's a high risk of perforation. Some of the patients are obese and the colon is looping significantly, and this lesion is also sometimes behind folds. So this is an example of how colonic ESD looks like. We have a granular lateral spreading polyps. We marked the lesion, and now I'm doing incision around the lesion. We are injecting the submucosa, and while we're injecting it, we're also dissecting it, and we're dissecting from the anal side to the oral side of the lesion. creating a bridge, as you can see here. And after that, we dissect the lesion entirely, and you can close the lesion. So this is a colonic ESD process, and this what takes time to learn, and sometimes a problem that you can have perforations or other problems. So how can you improve the training to do such a complex procedure? There is training pathways in the United States. We spoke about the animal model training and proctorship, but also these are the example of courses available here in the United States: Asian Master Course, ELSA training with Boston Scientific, Olympus training. There's a Florida Third Space Endoscopy Workshop. Here in Houston, we have the TEAG Annual Third Space Endoscopy Workshop. We have been doing it for 5 years. This year we'll have 16 stations. And there's the one from Cleveland Clinic, and these are the dedicated ESD courses in the United States. But also there are advanced endoscopy fellowship in the United States now focused on ESD. And the first one from Brigham and Women's Hospital. There is one at University of Florida, Mayo Clinic Scottsdale, and 2026 at Baylor College of Medicine, we're starting our ESD fellowship. There's an evidence that when you train fellows, it does not affect the procedure performance. Some of the endoscopists are worried about training that, oh, they will affect my outcome, but with good mentoring, you should have similar outcomes with the trainee. I'm going to highlight here another model that we use at Baylor College of Medicine, which is called Master Apprentice model. Basically, what it is that we get young faculty who are already practicing in our institution and teach them 1 day a week, and they watch 3 ESD and do 1. So watch 3 to do 1. And they keep doing that 1 day a week for a whole year. And basically that allows them to do other things, ERCPs, EUS, and focus 1 day of training, and slowly by slowly getting better without the pressure of doing too many cases. The first trainee here, faculty trainee, performed 55 cases under supervision. And in the next 2 years in her own, she performed 136 cases, and her in-block resection rate was 92.6%, R0 resection rate 8.2%, and these were the location of the lesions, mostly in the colon. Traction was used in most of these cases, and most of these patients discharged in the same rate. It was excellent adverse events profile, showing now that we decreased the learning curve from 268 cases into 5 cases, provided that this person watch a lot. So let's emphasize the rule of watching the entire procedures. I did this again with another trainee, and the trainee too, he's already did 11 cases so far independently, and he has in-block resection rate of 100%, was R0 resection rate of 91%. So how it is possible? At my time, it was very hard to do this procedure because there was lack of devices too. Now, as we can see here, we have too many devices that allowed us to do the procedure safely. One of the things we worry about is post-resection syndrome or perforation post-procedure. All of these right now can be treated with closure. This closure device was not even available to the Japanese expert when they started. So this one study we showed for 35 lesion who did ESD with suturing, that if you close the lesion completely with suture, you can send the patient the same day home, and you have almost 0 adverse events. So if we look at a lesion like that, is 90% of the circumference, and you can see at the end how it is closed completely. This patient will not have any bleeding episodes and will not have perforation, and you can feel comfortable sending them home at the same time. But this is how it looks like at the end. So suturing made training easier because people now can get trained and not scared about what would happen. This is an example of another device called X-Tac, and we're using it here for approximation of the edge and closure of a lesion in the ascending colon. And you can see here how you can use it for closure of the entire defect with no problem. So closure devices made it easier. This was one of our randomized trials using 2 closure devices, showing that closure does not take as much time now. So if we look at the approximation and closure time, it's 12 minutes with one device and 4 minutes with another device. So I was in DDW, and the Japanese never closed. And for the first time, because now some of these closure devices coming to Japan, and they asked one of the speaker question, do you close your lesion now? And they said, well, now closure take us only 10 to 15 minutes. We are closing the lesions. So the notion of no closure versus closure is totally changing. The same with traction. Traction devices are very useful for trainees because it allows you to pull the lesion away and make the submucosal space very wide, as you can see here. And having this large submucosa prevent perforation, as you can see. So I often use traction device for training, and I often use rubber band for that for training purposes. And as you can see here, my trainees, they do now 70% of their cases with tractions. Also stabilization devices like this one. In the colon, sometimes it is unstable and you're worried about the knife moving the wrong direction. Having over tubes facilitate procedures. This is one of the study that we showed here. You can do resect lesion 4 centimeter in size in 43 minutes using over tube. This is another novel over tube with, we call it dynamic rigidization tube. Once it requires suction from the wall, and once you suction, it can maintain the shape as it is. It's also use it now frequently for ESD, and we showed in our data here that actually is expedited the dissection speed to 10.1 centimeters square per hour. Also, electrosurgical unit is an example of using bipolar current in a lesion. It's a recurrent lesion that was injected under it. Mostly these lesions would be hard before associated with perforation, but using bipolar current, which deliver significantly a smaller amount of energy or less quantity of the energy, allows you to dissect with a nice clean base, as you see here, without causing perforation. So as you can see, there's many innovation in the field which allowed us to work right now safely. And lastly, I will touch on hemostasis device. This is an example of bleeding during ESD. In the past, you would spend a lot of time controlling the bleeding. That's one of the hemostasis devices, which is very transparent, allow you to put this spray, and then you can dissect while the area is bleeding, because it will stop the bleeding for you. So you can see here we had an active bleeding. We're not able to see the submucosa, and it just slowed down the bleeding significantly. And now we can start dissecting again. This is another agent. You can put both ESD, and it is a hemo spray or hemo powder. And this powder, you can add water to it, and it become crystallized and really cover the lesion base for 3 days. So now we have a lot of option. Even if you're not able to close, we can use some of these lesion. This is the last video I want to show before I finish. If you have perforation, you have error in the abdomen, just if the patient is back, you can go below the umbilicus or above the umbilicus and try to get the air out. I can use 14 gauge catheter. If the patient on their side, find the last strip and 2 fingers below the last strip, you can put it if they are on their side. So even if you had a perforation, you can always get the air out, close the perforation, and the patient will do very well. So in conclusion, ESD training can be obtained during practice. Innovation in closure and traction devices shortened ESD learning curve. Training in ESD should be coupled with making structural changes in your hospital and educating referring physicians about the procedure. Thank you so much.
Hello, Dr. Othman. Thank you so much for your brilliant presentation. I think you touched upon many topics about which we all have questions in terms of the learning curve. I wanted to ask you, in your training and the time during which you were perfecting your techniques, what changes did you observe from the moment that you started out up to now that you are an expert? What were the main changes that you observed in your practice of the third space? And has this changed your technique up to now?
So it changes in me or it changes on the field? Like cambios on me or cambios in it?
En su técnica en general, su
In-
técnica
In
con
your
el
technique
versión,
in general, the technique when you started out and the technique you use now, has it changed or has it always been the same?
Oh, it changed significantly and dramatically. So I would highlight few things that I learned over the year that I feel they made difference. Number one, using less energy. So I used to, when I do ESD at the beginning, blast the energy high, try to dissect so fast, thinking that that's better. And I learned that this actually can lead to post-resection syndrome. So now I'm more into using the least energy possible. If I have a bleeding vessel and I'm using coagulation grasper and I use it for 1 or 2 seconds, bleeding doesn't stop, then I look for another place where I can hold it from and stop the bleeding immediately. If I'm dissecting instead of using coagulation modes, such as forced coagulation, I'm using endocut mode and only use coagulation when I see blood vessel. So this was one of the main thing I think changed in my practice. Then another thing I start paying attention to, you have to make your resection look pretty. And why we love Japanese is because they do a beautiful job when they do resection. And part of it is that they pay attention not to injure the muscle. So now when I do an ESD, in my report, we put the Sydney classification, which is a classification to look at the muscle injury. We inspect the bed very well. We strive, me and my partners, not to have any muscle injury in the bed of the resection. Of course, this will happen, but you wanna do your best not to injure the muscle at all. Sometimes this will happen, but I feel change in my practice now that when I look at my old videos and my new videos now, I found that the muscle injury significantly less, and the charring, that black color, is also less. So the advice what I give everyone is pay attention not to injure the muscle, but also do not use too much of the energy when you're working.
Doctor
gracias.
Othman, muchísimas gracias también por su excelente ponencia. Tenemos una pregunta de
Dr. Othman, thank you so much for your great lecture. Another question from the audience. Part of your learning is to select the patient properly. In the specific case, when you train doctors, what are the key points that you consider that we should bear in mind as endoscopists before deciding whether the patient is eligible or not for any of these procedures?
Yeah, so it depends. If the trainee is working with me under my supervision, I might start doing the initial incision part myself and teach them first the submucosal dissection. I learned that teaching POEM procedure is much easier than teaching ESD. So a lot of time I start my trainees first in POEM. And for people who are practicing too, if you want to start practicing something first, POEM procedure is much easier because you can go in the tunnel straight and you can have a better results. And the other thing is once you go on your own, as you always want to start with a smaller lesion. Don't go for 5-6 centimeter lesion because the risk of bleeding and the risk of perforation will be higher. So at the beginning, no more than 3 centimeter lesion, gastric or rectal, or maybe nodule within esophagus would be the perfect starting lesion.
Tenemos otra pregunta. En lo personal,
Another
muchas
question,
veces
doctor.
tratamos de enseñar
Oftentimes,
a los
we try to
colegas
teach
o
our
en
fellows
periodos de formación en este tipo
or
de
in our
procedimientos
training periods
en
in these
áreas que sean
procedures
más
in
fáciles de
areas that are
realizar.
easier to manipulate at the beginning.
¿Dónde
In
creen
your
que se puedan
view,
realizar estos
where
procedimientos
do
de
you
manera
think these procedures can be performed in a more standardized manner with not so many complications upon beginning the learning curve in these procedures? The stomach, the duodenum, the esophagus, or the colon?
Yes. So I just want to touch on something. In the United States, there's 1 year of training called Advanced Endoscopy Fellowship. And a lot of people come to this 1 year, want to learn ERCP, EUS, and also ESD. And I think it is impossible. So in my institution, I don't offer ESD training for people who are just learning EOS and ERCP. Because that year you're learning EOS and ERCP, your brain is already saturated with a lot of new information. And I really teach ESD for people who already had training in these, or maybe they're not interested in EOS and ERCP and just focus on ESD. Having said that, the people who are trained in ERCP and EOS, once they are in practice, they can learn ESD faster than the one who are not doing it, particularly ERCP, because ERCP skills teach you fine movement. So I wouldn't start any trainee in a case in the duodenum. In fact, I would say no one should try doing duodenal ESD till they did at least 200 plus ESD, because the risk of perforation is much higher in the duodenum. I would say rectum and transverse colon. So I start first rectum, then I give them lesion in transverse colon, and after that ascending colon, and then after that cecum, and later on sigmoid colon. So believe it or not, in my opinion, sigmoid colon is the toughest area in the for colonic ESD. The reason is instability. This area is very unstable. You're close to a lot of diverticulosis. Also, when you insufflate, you are not able to insufflate very well because the air goes out and the space is narrow in the sigmoid colon. So if I would divide the colon, I would say rectum, transverse colon, ascending colon, cecum, then sigmoid. This is how I grade the lesions. And esophagus, if it's a nodule between 2 to 3 centimeter, it's good for trainee. Something more than 50% of the circumference might be very hard. So I would just do the circumferential incision and make them do the tunneling.
Tenemos otra pregunta, doctor Othman, de la audiencia.
Another question from our audience, doctor, regarding endoscopic dissection of the submucosa of the rectal sinuses. They say here that sometimes it is necessary to adopt a position of the scope in retroversion, and this adds more technical complexity. What advice would you give people who do endoscopic resection to improve the complexity in retroflexion?
Yes. So I agree.
Estoy de acuerdo.
Dissecting in retroflexion is hard. And for this reason, I would give an advice that before you inject the entire lesion, just inject behind the lesion. And if you inject behind the lesion first, you will raise that bar and you can do the back border without retroflexion. So I will tell you, in my style of doing colonic ESD, I rarely need retroflexion even in the rectum, because you can raise the lesion first, the back border, and do it in forward view. However, if you want to get better in retroflex, working retroflexion, you can do that in animal model, but also certain scopes are better than other in retroflexion. Sometimes when you have a hard time with retroflexion, it's not your fault. It's in fact, the problem is with the scope itself. A lot of the scopes cannot retroflex very well, and that's why you have a tough angle. If you notice in Japan, they have a scope, and maybe you have it in Mexico, called TL scope from Olympus. And that scope has double bend, and these double bends allow you to do retroflexion. Another thing, in the rectum, I use EGD scope because it retroflects better and it allows you to work in the rectum. A third thing, there's certain manufacturers have better scopes, and also you can look at your unit before you go to the procedure, retroflex all the scope and see which one can retroflex the most and use for the ESD. And sometimes I do that. So a lot of time it is not your fault. It's a problem of the scope itself. But using EGD scope will help, or double bend scope if you have it.
Correcto. Muchas gracias por sus respuestas.
Great. Thank you so much for your answers, doctor. Now, during your presentation, you talked about monopolar knives versus the monopolar versus bipolar. I personally believe that there is some evidence where they tell us that bipolar injures less the muscular layer, and therefore there's a lower risk for injury. Do you have any criteria to select cases between monopolar versus bipolar energy?
All right, this is a great question. And honestly, I feel that the field will move toward bipolar energy in the next 10 years. Here is a problem we have with the current bipolar energy. When you dissect, it bleeds a lot because the cut is still pure cut. So you have to be very careful. You coagulate first, then cut. Unlike the monopolar, when you have endocut mode, which is mixed coagulation with cutting current, in the bipolar device we have in the market right now, it is a pure cut with coagulation. If you pay attention to this and you pre-coagulate, and by the way, when you pre-coagulate, you are delivering 1 in 100 from the energy you would deliver with a monopolar knife. So you don't feel uncomfortable about pre-coagulating as much as you can. So I do pre-coagulate and cut, pre-coagulate and cut, and carefully look for the blood vessel and pre-coagulate them. And actually, you do very well. My criteria is non-bulky lesion. So flat lesions work very well. I start actually poem. 90% of my poem now are done by bipolar knife. We just finalized a randomized trial for 3 centers between us at Baylor and the AIG in India and another center in Spain, Dr. Eduardo Alpanese. And the three of us compared monopolar versus bipolar, showing that bipolar energy is efficient. There's also something I noticed with my patient. Although pain post-procedure was the same in our trial, which happened because they just cut the muscle, the patient feeling pain. When we brought them later, we were doing a quality of life questionnaire for another trial, and we find that the patient who felt they are back to normal within 1 to 2 days always had bipolar energy device for their procedure. So the amount of energy you deliver doesn't only have an immediate effect on pain, but also it has an effect on recovery time later on. If you notice the field of ENT and neurosurgery, they all move to bipolar current. And I feel within the next 5 to 10 years, the ESD field will move toward less energy or bipolar current too.
Doctor Othman, ¿tiene alguna utilidad
Dr. Othman, is it useful to use AI in the learning process of these advanced techniques?
It's extremely useful. However, we don't have an AI yet to show us where to dissect. I wish to do it. I have actually tried with many groups, and I have been working on a project right now with Dr. Carlos Robles. He is an amazing person who have a good team of AI engineers, and I sat with them, and we're trying to do this. We're trying to make a software that can highlight the submucosa for you to dissect. I think in the future we'll be able to do that. The AI systems we have right now is only focused on detecting lesion rather than detecting the submucosal space. But I think the future will include AI definitely.
Preguntan también, doctor, que el
Also,
curso que
they
menciona
ask,
que
Doctor, the course
está disponible
that you mentioned that is available in Houston,
sede y las fechas.
what is the venue? And do you know the dates? There's a lot of people who want to go.
So with our next course is the end of May, is actually end of this month at May 30th. And we have only 2 spots left as of today for that course. The 30 spots was already filled. I did not expect, we have 32 trainers and 32 endoscopists, basically 32 trainees and 32 endoscopists. So there will be 32 experts from United States in ESD and only 32 trainees and 16 stations. So that's why it's very popular and it's almost closed. But whoever would like to register, there's two spots left. It would be a Friday live endoscopy course, watching 8 ESD cases and third space, and Saturday training for 8 hours on ex vivo animal models. And we do that every year. So whoever missed this year, you can come next year, definitely.
Perfecto, doctor. Una última pregunta.
Great, doctor. One last question. One of the hardships of implementing these techniques, at least in Latin America, and I guess also in the United States, at the beginning is kind of like changing the perception of cancer doctors, telling them that with these techniques, we can also cure a patient or a precursor gastrointestinal cancer lesion. What have you done in the States to let more patients adhere to these techniques, not to require a surgery?
It's more about educating the referring physicians, and a lot of time the patient would read the web pages. So we do have a web page about ESD. Educated patient will read about it. Patient who trusts their physician, then you will have to educate their physicians. So I felt what really made a big difference is to teach general GI doctors in the community about the importance of ESD, and they communicate that to the patient. One of the most difficult situations is when you get a patient who his doctor told him you must have a surgery, and then you are telling them, actually, you don't need a surgery. So I learned that I don't argue. I offer patient what we have, what the advantage of it, explain to them the risk, but also allow them to make their decision. But over the long term, I'm educating the doctors in the community about ESD and its outcomes. And I think if the patient seen by the doctor got referred to me, telling them that it's their best option, they will adhere and will do whatever need to be done, versus when their doctor don't know about the technique. So teaching doctors is the main thing, actually, more than patient.
Y ya para concluir, doctor, quisiera...
And in order to wrap up, doctor, maybe some key points as take-home messages, doctor. And also Dr. Ariostos, regarding the third space techniques.
Okay, so I would say key point, most important point is be patient. ESD learning curve is hard and it might take time and everyone is different. So before I started ESD, it took me 1 year and a half from the moment I start training till I did the first case. So it is okay to take your time till you feel comfortable. And once you feel comfortable, you can start. Unlike ERCB and EUS, you can train in animal models. So spend more time in animal models. Spend at least 20 to 30 hours training in animal models so your skills gets good. But also remember that no matter how good you are, you might have adverse events. And when adverse events happen, do not let them make you scared from doing the procedure. Like all of us, when we do ERCP, you get post-ERCP pancreatitis, you feel bad, but you move on and you do an ERCP next day with no problem. And the same in ESD. You will get a case when you'll have a perforation or patient will end up having surgery. Do not allow this one bad experience to affect all the hard work you did and affect your trust in yourself and your ability.
El doctor Othman.
I would like to add something. Patience is the key. There are international clinical guidelines of each of the endoscopic procedures for the learning curve, such as ERCP, ultrasound. It is well defined for ultrasound, 250, and I believe he said 300 for ERCP. Unfortunately, for ESD, there's no guideline, but there are indirect data through studies where you see the improvement in the learning curve. I don't think nobody in a hospital will let a first-year resident do an ERCP. Ideally, the training should be on a step-by-step manner, starting with ex vivo models and then move on to live porcine models where we can have the bleeding model. And then when you will have your first patients, the recommendation is for you to be accompanied by an expert to do the procedure. And later on, as you will gain confidence, do cases in simple places. I think that the stomach, in my view, is a good place as you have a lot of space for maneuvering. But I think you have to be cautious in your learning curve because at the end of the day, the one that pays the consequences is the patient if you're not properly trained in these procedures. Well, thank you so much. And we would like to thank Dr. Othman for taking the time to give us this excellent lecture, and to Dr. Ariosto for joining us as a national professor. About 160 participants joined in from Mexico, Peru, Ecuador, Anguilla, El Salvador, and Guatemala. Next, let me give a couple of important housekeeping messages regarding the activities of our dear society. We would like to invite you the Leader Jack program, Endoscopic Advanced Capsule. The online course will be from 19 to 24 May, and the in-person group on May the 30th. This will give you points for recertification, both the theoretical as well as the in-person course. From June 6 to 7, we have our Northern Regional session in San Luis Potosí. We will have top quality and national and international professors, and also hands-on courses. It is important to remind you that from July 17 to 19, the International ECHOS program will take place at the Hospital Español. Our first number of our journal is ready. We would like to invite all our members to publish their papers in our journal, and please be advised that we will soon be publishing the enteral accesses and nutrition guidelines from the Society of Gastroenterology and professionals. The next monthly session will be June the 5th, pre-malignant lesions. How do I detect and treat timely, with our international professor, Dr. Eduardo de Moura from Brazil, and our national professor, Dr. Jose Miguel Espinosa Gonzalez, and for our chairwoman, Dr. Zamorano Orozco, and the whole Board of Trustees. It was an honor to have you join us in this session.